And share screen. Here we go. Okay, so Mycobacterium, what we're doing today. So we have about 3 of these are really, well, you've heard of 3 maybe through the day, through the lecture. But these are still around, and we still have issues with TB. So TB was almost eradicated. I mean, it was so close to being pretty much nobody was getting it anymore. And then we had a little outbreak of HIV in the early 80s, late 80s through that, and it kind of revived it. So it's been around. It kind of had diminished up to the 80s and then kind of has resurged. So you do still have it, still see it in your patients. But the big thing about Mycobacterium is that it is acid-fast rod. So acid-fast bacilli, and that's our quickest way of finding out if the sputum has a Mycobacterium in it, as we do an acid-fast stain. So they're usually rod shaped. They may be cocci, they may look filament. They're non-spore forming. And the reason we have to go to acid-fast stain is because the incubation time to culture Mycobacterium can be 6 weeks up to 8 weeks. Okay, so it takes, if we send this off, we'll be long forgotten about it when we get the result back. So it takes that. It's a long time to culture it. So we need a faster way, and that's where the acid fast comes in. That we do that in the lab. We can do it on the sample itself, and then say acid fast bacilli, seen or not seen. That's kind of how we report it. That kind of gives the doctor the go ahead to suspect tuberculosis. So there is other ways to detect it, and we're going to see some of that too, especially with X-ray. So how many of you had TB skin test done? So we start that way. So we had a few. Me, right? Anybody had a reaction? You had a reaction to TB? Okay. What did they do from there?
I don't know why.
You don't know why you had a reaction? Well, probably because you've been exposed sometime.
No.
Yeah.
I took the vaccination when I was a child, so maybe that is the reason.
Could have. Like you took a vaccine against Mycobacterium?
I don't know. That is another vaccination.
Yeah. So if you do have a positive test, positive skin test, the recommendation is to go get a chest X-ray, and they look for any tuberculin nodules in your lungs. Because what it does, if it gets in your lungs, it gets walled off, and we're going to see that today. But yes, the skin test is a sensitized method, you know, that we've covered in immunology. So we're going to kind of cross over the two here this week. So here, a slide. So, you know, the question is, well, what is it really? Where could we classify it as in your book, your chapter? Kind of get you, you know, there is a difference in the cell wall of the Mycobacterium. That's the reason it doesn't stain gram stain. So gram staining is not what we want to do with this. So that's where the acid fast comes in. So we need to do a little different staining mechanism. And they have a high lipid content. But if we were going to call them anything, right, they generally are considered gram positive. So gram positive rod, but you won't see it on the gram positive side because they are different than the gram positive organisms. But if we were going to call it one way or the other, that's where we would lean. So if you get ever asked that, like, where would you put Mycobacterium? So public health. So we give a little background. Estimate 1/3 of the world's population has been infected with TB. Most of these infections are not active and cause no symptoms. The individual's immune system has effectively contained it. So, you know, that skin test is to say, well, maybe 5 years ago you got exposed to it. You know, you ramped up an immune response, and you've been sensitized with it, so that's why the skin test was positive. Highly industrialized countries, only a small number of cases, and that's what we're saying about the United States. We thought we had it pretty much where we wouldn't have any more cases, active cases, but increasing immunocompromise, and that's our HIV, our AIDS patient, kind of had a little rebound. So it's not that the AIDS patient was the only one that could get it. They were the ones that the cases started rising there, and then it led to other cases past the HIV patient. So cancer patients can be at risk, leukemia, lymphoma, transplant patients, AIDS, immunodeficient patients suffering from autoimmune disease or that are under immunosuppressive therapy can be susceptible. Developing countries, this is where we see most of our cases now worldwide, 20 million active cases. So infecting another 50 to 100 million individuals. 3 million people die each year from diseases caused by Mycobacterium, and 80% of those are in developing countries. So developing countries, overpopulated countries, and you put a lot of people in the same areas and somebody has this, so you can gather that this is a respiratory spread bacterium, okay? So this is one that you would get just by hanging out around the positive patient. And that's where healthcare workers are at biggest risk, right? We have somebody come in with TB into the ER, before we get to the chest x-ray, before we get to the history, before that, how many people have been exposed? All right, and that's how it happens. So healthcare workers are a big risk as they come in. I don't know if you catch the news, but sometimes we hear stories of a TB patient just leaves the hospital. And that happens in Little Rock quite often. And they will go searching for them because they don't want them out spreading it. So I've seen that a couple of times from Little Rock hospitals where they have an active TB patient and they're treating them, but they decide they've had enough of that treatment, and usually these individuals are in a socioeconomic status, maybe homeless, and they just decide to walk out of the hospital and go about their business, and they have to go search and get them back so we can isolate them so they're not spreading it around to the public. So acid-fast bacilli, that's the group we're talking about with Mycobacterium. These organisms are similar to each other biochemically, serological, and pathogenic characteristics. For example, one of the ones you may have heard of is Mycobacterium avium complex, the MAC. Includes opportunists, which cause chronic pulmonary disease. So I think the few Mycobacteriums I've collected that were acid-fast and then sent off for ID actually came back as avium when they got back to me. So they weren't tuberculin or tuberculosis, they were more of an avium. But they gave all the symptoms, in the sputum, patient suffering pulmonary with it. But when it finally got back, it was not tuberculosis, it was actually avium. The tubercular bacillus complex. So we have the avium complex, we have the tuberculin complex, and this is why we call it tuberculosis. So Mycobacterium tuberculosis is the big one that we worry most about. What is this complex? It's a primary agent of tuberculosis in the United States. You see it in other countries. In Africa, it's called Africanum. And then bovis, one of the ones we had earlier, Mycobacterium bovis, early 1900s, this one infected cattle, and then the humans would get infected if you drink the milk from the cow that was infected. And now we know that we have pasteurization, but like I said in previous lectures, there are still people that do not pasteurize their milk. They like fresh milk, and they'll take it right from the cow, and they'll go put it on the table for breakfast or dinner or whatever. Okay, so still have that. So just because it says 1900s and we think we don't have to worry with it, you don't have to know. So here's a farmer from the early 1900s, and this is the udder of the cow that has tuberculosis. So tuberculosis This walling off happened in the udder of the cow, and then the milk would then be infected. Then we started pasteurizing. Yay, good for that. This is it on a scanning electron micrograph. It is rod shaped, but it could be a filament. Wouldn't confuse that with a cock's-eye. And then on our auger plates, growth-wise, you see that it has, it's you know, definitely looks like, what would you call that? Look. Ground glass, maybe. That's what I'd like to call it. Growing on a slant. So, and then here's Bovis growing on our 7H10 auger. So they all look pretty much the same growing once they get growing. And then we have a classification system for them. And so we'll start with the non-tuberculosis Mycobacterium. So there are some that do not cause tuberculosis. Yay. So we classify them as the NTMs. And these are not Mycobacterium tuberculosis or Africanum or Bovis. These are ubiquitous in the soil and water and cause pulmonary disease, identical to that produced by the tuberculin bacilli. However, they're strictly opportunistic. So, you know, to a point we were like, oh yes, you know, even TB is considered opportunistic, but not anymore. Healthy people are susceptible to infection of the non-tuberculosis Mycobacterium. They can infect skin, bones, joints, lymphatic, soft tissue. And this is what's crazy, right? Incubation period exceeds 5 years. Often requires prolonged treatment. It can lead to sepsis and death. There is extrapulmonary outbreaks. And look this, all right, who knows what a surgical gentian violet is? What is a surgical gentian violet? I think about a TV show I used to watch. It was called Hollywood Plastic Surgeons. Did y'all ever watch that ever? When the doctor would have somebody in front of them and they'd start just drawing all over them, right? That's what I consider a surgical gentian violet marker. So that could be a spread into the tissue. So they're just marking your skin for surgical procedures. Nail salon pedicures, we've all been there, not right? Right. Tattoos, another reason not to get a tattoo. Sure don't want to get a non-tuberculosis Mycobacterium infection. And then we have our Runyon groups. So this is old school, Runyon 1 through 4. Those are the old names. So we really have new names and we've given them names. So you could just basically put Runyon 1, 2, 3, 4. Runyon 1s are photochromogens. We're going to talk about how they change colors. And then we have scotochromogens. And then we have non-photochromogens and we have rapid growers. So it's basically their pigmentation helps us classify the acid-fast bacilli. So group 1 is the photochromogens. These organisms are non-pigmented in the dark, but as soon as you take them out of the dark and expose them to light, they get this carotenoid pigment. And the one we have here is Mycobacterium kansasi. Be in the number 1 group. So while this plate was growing in the dark, there was no color. You bring it out into the light and you start seeing colored pigment on top of the growth. And remember, these took 6 weeks to get here. Okay, they're very slow growing. So it's not something we put this in the incubator last night and boom, look at it. Wish we could do that with Mycobacterium. That would save us a lot of time and effort, but we can't. Ground glass appearance. There's that pigment, carotenoid pigment, once exposed to light. Number 2 is the scotochromogens. Produce a yellow to orange pigment in the dark or light, but the color deepens when you get it into the light. So this is Mycobacterium sluesgii, all right? I think we say the S and the Z. I think it's Suesgila. I think so. There it is. Can't miss that. So here's 2, and that's dark or light. So it's not one that you can hide in the dark and then comes out. This one will, when light hits it, it really, really enhances the color. Number 3 is non-photochromogens, and these may possess light pigmentations. And remember, these are the non-tuberculin, non-tuberculosis. So this is avium complex. Light pigmentation ranging from white to buff, tan, pale yellow, and then exposed to light, the pigment does not intensify. So this would be just kind of a dullish look to it. Not a whole lot of color on the group 3s. And then we have the number 4, the rapid growers. They the mature colonies within 7 days. This is Mycobacterium fortuatum. So only a week to get fortuatum up. But you still had to wait a week. Almost a fried egg look to that one. All right. Safety, we know, right? We're all up on safety and respiratory safety. If it's transmitted through respiratory droplets, we know how to prevent aerosols. So should be avoided. Use a biological safety cabinet if you're dealing with this one. Gown, mask, and gloves. And PPD, purified protein derivative, that's what the skin test is now known as, PPD. And that's where we demonstrate exposure to Mycobacterium species with a serial conversion and sensitization. And then if we did get that positive test, we should go get a chest x-ray to make sure we don't have any signs of tuberculin. Okay? We call it the Mantoux test for those that are not in our immunology class. So here we are back in the 60s. Love these historical pictures. There's a good one, right? I want to see that puff up. And we do the little hypodermic needle. Here we are measuring it. So this is that, you know, the wheel, right? Swollen wheel and flare. Look, I can see that under his finger. Definitely a positive reaction. Measuring it some more. Positive skin test. So, and it's up to you, really. I mean, I don't know. Did you know you were positive, or did you have to have a nurse tell you were positive?
I know it is positive.
You knew it was positive, right? And they'll ask you that because God, some people will have a little flare up at the beginning, and then actually when it's 2 days later, it's not there anymore. And they'll ask you, they'll say, did you have any swelling, raising, flaring? And of course, you always go, no, I didn't have anything like that, right? So I've always wondered that. Do we really just, you know, are we hurting ourselves by saying, yeah, no, I didn't have a reaction, right? And then I told you, like, the newest thing I got this past couple of weeks was that the hospital is now asking that you just do a survey each year, not even do the skin test anymore.
So when we go to clinicals and do the tests and stuff, are we doing it or no?
That'll be up to the clinical site. So they may require all students before you come in to have a TB skin test. Now I had to get one as a new employee. I had to get one, but
That's
so
why
I would
got
think
mine.
so. I would think the students would have to get one. But after that, if you got employed there, could you just survey it out each year?
I think everybody has to get one before they do any clinical rotation.
Sounds right. Yeah, sounds like a
teachers have to too.
procedure. Sputum. Sputum is our friend here with collection. It's not the only sample though. Just keep that in mind. It's the most often used, and it's the one you will be testing out. If you ever get an acid fast order, it's going to be out of the sputum from the ER or the floor. And it's sputum, if you hadn't figured this out, it's the thick exudate, productive exudate. It's not just spit. So when it says not watery saliva, we don't just say spit in the cup. But the thing is, I usually want 3 specimens, 3 consecutive days, okay? That gets harder for the patient to do, and that first one might be really good. So usually we rely on respiratory to come in and help us produce this, and they'll help the patient produce some patients can't even produce the sputum though. They just don't have any respiratory problem. So you hope that when they order a sputum, they actually are having productive cough and clearing of the lung and can get that up so they can put it in the cup. 5 to 10 mils, usually, just a little cup of like a urine cup. That's usually where I find it. Sometimes they'll give you the conical inside the collecting device. I've had that given to me before, where you have to just dismantle it to find your little 50 mil conical with the blue top on the bottom. That's a fresh one, right? They bring that whole thing into you or bag it up and bring it in. And pooled specimens are unacceptable. So what happens, right? The nurse brings that in to the patient, says, here, every time you cough, try to put it in this cup. How many times how long did they leave it in there? How many times do they cough up through the day to put it in there to get something, right? So these need to be a one-time deal. We walk in, that's where you get respiratory to help you. Hey, I need a sputum collected. They'll go down to the room. They'll go in with the patient. They'll aid them in getting it coughed up and collected, spit into the cup, and then it's done. Don't be the, hey, let's leave it in the room and see how many times I can spit in it during the day to get 25 mils of spit in there for you. That's not going to help us, all right? We want a sputum. Gastric lavage, I've never had one this way, but hey, patient must fast for 8 hours. Woo, okay. We're gonna pump out your stomach a little bit. We're gonna run some stuff through. Early morning specimen. Patient swallows a gastric tube, sips on some sterile water. All right, 20 to 30 mils of sterile water are given by mouth. They're injected through the tube. The stomach contents are aspirated into a 50 cc syringe. I've had gastric juice brought to me before, and it's usually though an induced vomiting, like somebody's ingested something they shouldn't have, and they've induced their vomiting, and they brought that to me. But I've never had a gastric lavage for acid fast bacilli. We want to process them quickly, within 4 hours. So that's why I'm saying a fresh sputum. Go ahead and get it to me. I can go ahead and get this done, and I can culture it, and I can do acid fast on it. Urine. We can do a urine for acid fast bacilli. First morning specimen, 50 mils. Centrifuge it for 30 minutes. How many of you anybody had body fluids yet? No? You have? Did y'all talk about acid fast bacilli with urine and spinning it for 30 minutes?
I think so, yeah.
Did you? Good. Good. All right. I've never had that.
Don't hold me to it.
Huh?
Don't hold me to it.
Well, I've never had that collected that way either, though. Many specimens contain contaminating organisms. So we have, with sputa, gastric acid, or urine specimens, all these have other organisms we don't really care about. So we can get rid of those. So we get rid of them by using sodium hydroxide, N-acetyl L-cysteine, the NALC, and sodium hydroxide are the most common digestive decontaminants. So the NALC, the mucolytic agent, liquefies the mucus and organic debris. The sodium hydroxide is a decontaminant that kills the contaminant. So we can treat those specimens and get rid of all that other normal flora that can be in all this stuff. To get a sterile specimen, though, you don't have to do the decontamination. All right, staining. Well, this will be in your micro section of your lab. And usually there's a setup for gram stain, and then there's a setup for acid fast staining, if your doctors want that. Hopefully they will. So this gives us a rapid diagnosis. It's not sensitive as to culture, so we can just say acid-fast positive. We can't say probably Mycobacterium tuberculosis, right? We can't say that. We can say acid-fast positive and give them a heads up. Gram staining, very hard to get it to look as where we want it, right? Gram positive, and what happens is the cell wall becomes impermeable and impermeable, and it can't get the stain in there. But the acid-fast, you can. The cell walls, they resist decolorization with acid alcohol, and what we do here is we get that acid-fast in there, and it turns it reddish. Okay, carbofuchsin stain is the stain that we use. It imparts a red color, the Ziehl-Neelsen. Viable acid-fast bacilli retain the red color while all organisms are decolorized. And then you counter stain them blue, okay, with methylene blue. So if you look at it, you'll have probably carbofuchsin stain. Usually it won't be 3 bottles for acid-fast, it'll be 2 bottles. Okay, so it'll be a carbofuchsin in the front, and it'll be a methylene blue on the back. And what you're looking for is that carbofuchsin stain, that red color, to stay in the bacteria after you're done, and everything else will stain blue. So we can see that. So staining of sputum, right? We'll make a thin smear of the sputum across the slide. Then we're going to do an acid-fast stain looking for red rods, right? Fluorescence, be great. Yes, it would be if we had it. Not all of us will have it. Sorry. Fixation, 65 to 70 degrees Celsius for 2 hours. Stat stain using sodium hypochlorite. And for us though, we're just going to be doing acid fast. I don't know if we can get it to 65 to 70 degrees Celsius. That's pretty warm, isn't it? Yes or no?
Yeah, pretty
That's
warm.
room temp, right? Right.
That's almost,
That's
that's
hot.
boiling.
It's very
Well,
hot.
it's not boiling, but it's.
Very hot, yeah,
it's
very
in
hot.
there.
All right, so what if we needed to put it on something? What if we need to culture? What if we want to send cultures in? You know, instead of just sending the sputum, maybe we want to go ahead and mount it on something. Maybe we want to do our own. Maybe we want to hide them and put them in a separate spot and wait on them. One of the media that we use is called Lowenstein-Jensen, and it's an egg-based media for your notes. Egg-based. It has natural ingredients of whole egg, potato flour, salts, glycerol, malachite green. I don't know if malachite green is a natural ingredient. It might be. I don't know. I'm not. Advantage, greater number of positives, and neutralization of toxic material by whole egg ingredients. So we can culture it. And this is what they're going to do. Once you send it somewhere, they're going to culture it and wait on it to grow. We can also use Middlebrook 7H10 or 7H11 media. And these are chemically defined medias, and they contain salts, vitamins, oleic acid, albumin, glycerol, dextrose, malachite green. Quicker growth and transparency allows visualization of the morphology microscopically. So for us, an acid-fast bacilli, we can either use Lowenstein-Jensen, a lot of natural ingredients, egg-based, Middlebrook 7H10, and while I'm going back and forth with these two names, I recognize these as important for exams, okay, for acid-fast media. Both the egg-based and the agar-based media may be selective because we can add antibiotics to inhibit the contaminants. Liquid media, use Middlebrook. And then here at the bottom, Mycobacterium requires the 5 to 10% CO2. So we need to put it in the CO2 incubator or candle jar to increase our CO2 content. Questions so far? Yay. Okay. Clinical significance, I think you know a lot of it, but we'll go through it. Some more history for you a little bit. TB infections, the disease caused by microorganism Mycobacterium tuberculosis, among the top 10 causes of death in the world. Mostly affects lungs. According to the World Health Organization, 10.5 million people fall ill and is responsible for 1.8 million deaths, and this is from 2015, these numbers. It can be cured. We've got treatment, we've got antibiotics, okay? Some of these strains are becoming resistant, so that's our key to keeping that patient in Little Rock till we get the treatment in, because we don't want the patient out with a half-treated specimen of TB spreading it, because we might end up with a resistant strain of TB. And that's what our fear is most. So we want to make sure the patient goes through the full treatment regime, and there is a regime for this to make sure that they get treated and get cured before they spread it. The World Health Organization estimate almost 50 million lives were saved in the last, which we want to just say the last 15 years, through effective diagnosing and treatment of the disease. The entry is through the respiratory tract. I think we've already established that. Inhalation of respiratory droplets expelled by an infected person. Miliary tuberculosis, a dissemination of M. tuberculosis to other parts of the body, meaning that the lesions rupture and then they're transferred out of the lungs to other parts of your body. So it's kind of like a metastasizing of the tuberculum. Secondary tuberculosis is where it reactivates from a latent TB due to breakdown of the immune system. So somebody could have it walled off in their lungs. It could be tuberculin, what they call that, walled off, and then all of a sudden you go into an immunosuppression, and they might have asked anybody that's done the antibody treatments that we talk about in immunology, that have you had certain things before? Because when you suppress your immune system, those other things can revive, okay? They can come back, reactivate. So a lot of times you have to go through the whole list of, have you had this, have you had this, have you had hepatitis B, have you had tuberculosis, all those things, because when they suppress your immune system, it gives these organisms that may be suppressed in your body a leg up to come back. So what is the tuberculin? What is that? That is macrophages. Okay, so macrophages have surrounded the organism, puts them in a concentric circle, forms what's known as the granulomatous tubercle. The center of the tubercle disintegrates and forms a cheese-like mass. Ugh, right? Caseation. If a good cell-mediated response results, multiplication and dissemination ceases, and the lesions heal into a fibrotic calcification. That's what we see on the X-ray. Okay, so X-ray confirms that for us. The immune response was insufficient. This caseous mass in the lungs is liquefied, okay, by hydrolytic enzymes of the macrophages. The bacteria multiply in large numbers when the lesion ruptures, and the organism spread to other parts of the lung and into the environment. This large outpouring is responsible for highly contagious nature of tuberculosis. So again, if we can get to this, we can get to the walled off tuberculin where it actually puts a wall around it. But if we can't, then that patient becomes highly contagious as they go about their business. So 2002, emerging infectious disease. TB, why is it back? How can we protect ourselves? So these are some of the early 90s, right after HIV was getting it, coming through with numbers. So we we would love to have said there's no more TB, you know, there's no more cases. We don't see it anymore. We only see it in, you know, certain areas of the world, and we hope it, you know, we've got it under control. Didn't quite get there, almost did. So a historical picture from 1932. Oops. Uh-oh, where were we? Oops. There we are. Okay, we found a tuberculin in the lung x-ray. There's something in there, nurse. That's what we're talking about right up here, falling off. That right there, okay. Calcifications show up as white on x-ray. See macrophage. This looks like in the placenta. Endometriose. So we know, hopefully you got from, you know, bovine being in the udder of the cow, these can go to different areas. This is not always in the lung. Here's a culture from 1963. I think I still have these tubes in the back. Y'all like to see them? So we've kind of advanced. We got this is what we should look like. Protective equipment. That looks like an N95 mask. Still a lot of exposure, exposed skin. Adenitis scar, meaning it disseminated out. Susceptibility testing, and we'll talk a little bit about the susceptibility at the end, like which drugs we want to use to treat the regime, what the regime of antibiotics is for tuberculosis. Again, great for a picture, but we're not wearing gloves, right? All right, so that was tuberculosis. Then we have our non-tuberculosis mycobacterium, also known as mycobacterium other than tubercle, Mott bacilli. Y'all see Dr. Mott's downstairs, don't tell her this. Immunocompromised host of the population at risk. Transmission, probably from fresh water and the soil, environmental. AIDS patients, of course. That's where our rise in avium, Mycobacterium avium, is the AIDS patient. And here we're isolating it from blood and stool. So we were able to see the other areas of isolation. The most important disease associated with non-tubercle mycobacterium is chronic pulmonary disease of Mycobacterium avium complex and Mycobacterium Kansasii. Kansasii. Myrinum and ulcerans, localized cutaneous granulomas and ulcers associated with water and injuries involving swimming pools, handling of fish in aquariums, skin disease. These organisms grow best a little cooler at 30 degrees Celsius instead of 37. Crohn's disease, you know, we think that's an autoimmune, maybe associated with mycobacterium. Pathogenicity, because you know, with the Crohn's, I don't know if you know this with Crohn's, but certain section of small intestine just kind of dies out, okay, becomes blocked. Is that a tubercle at that area of the intestine? That's why I was bringing up Crohn's. They have to go in and cut that area for surgery, but it usually comes back, same spot. So it just returns to that area. And then pathogenicity to Mycobacterium tuberculosis is associated with something called cord factor. Now this is something that just sticks out of the wall of the bacterium. And you'll see cording. So pretty unique there. And then we switch over to another one. Have you heard of this one? Anybody? So this has got us over on, looks like about 533, looking at non-cultivatable, non-tuberculosis, Mycobacterium leprae, otherwise the cause of leprosy. Also known as Hansen's. India, South America, Africa, Southeast Asia. It's virtually eradicated from the Western countries. You might want to know how they eradicated it.
I used to like shun them. And have them.
Shun them, put them in their own little community.
Yeah, they
Yeah.
just killed off.
Kind
Or
of
died.
kind of a sanitarium for lepers, right? Still, yeah. Not too long ago. You head down to Louisiana, do a little touring. Mycobacterium has 3 clinical manifestations: asymptomatic, no clinical symptoms. You get a tuberculoid. Some resistance, but it is inadequate. There's usually a few or single lesions, erythematosis, hypopigmentation, plaques, flat centers, raised, demarcated borders. Infectivity is low. And then there is the lepromatosis, extensive skin involvement, tissue damage. So there's 3 levels. Nasal mucosa membranes are infected, severe, or serve as a source of shedding large numbers of organisms. So these people are contagious. Involvement, peripheral nerves, patchy sensory loss. There is very poor resistance to disease. Acid-fast bacilli are abundant in the skin lesion. And if it's untreated, the disease is progressive. Infectivity is very high. FYI, chronic infectious disease usually affects skin and peripheral nerves. Patients are classified as having palsy bacillary, multibacillary Hansen's disease. Palsy bacillary Hansen's disease is milder than multibacillary Hansen's. So what are the case numbers? And around 2010, there were over 200,000 cases of leprosy in the world. The disease is rare because of immunity that 95% of the population has against it. That's nice to know. And eventually, 95% of the population have resistance or have a immunity to COVID. Maybe. In the 80s, the World Health Organization began its leprosy elimination project. Since then, only 14 million cases of disease have been cured, over 14 million cases. Cultivation cannot be made on artificial media, so you need a live culture. And there is our friend, the armadillo. Okay? Has everybody ever heard of an armadillo having Hansen's disease or leprosy? Natural host. Okay? It was once told that anybody have, before I go in too much into this, anybody have a pet armadillo at home? No? Okay. Just checking, you can. I mean, I've seen those little squirrels those little things that ball up, but this would be like a big roly-poly. But their ears, right, are cooler than the rest of their body, and that's a good spot for this Mycobacterium leprae to grow. So they are kind of a host, and they're used in research to culture this stuff. There's 4 of them right there. So diagnosing Mycobacterium leprae based on clinical manifestations and a demonstration of acid-fast bacilli in tissues. Here's one similar, but it is a change in the name. Note that this is lepromatosis. There's another bacterium that causes a leprosy, Hansen disease. It's only recently discovered in the late 2008. It's associated with diffuse lepromatosis leprosy, DLL. It's mainly found in Mexico and the Caribbean, so getting closer to home. Okay, leprosy, lepromatosis. So Mexican cases of leprosy, definitely this would be the strain causing. 15 to 25, 23% in Mexico. It is unique, severe form of leprosy. And of course, you knew we'd have pictures, right? Couldn't go through a leprosy lecture without pictures. So some deforming pictures of the hands and face. Losing, it looks like fingers and toes. Nodular leprosy, 1905 case. Borderline lepromatosis. Hypopigmentation macule. And we'll go through some of the countries: Bangladesh, hand missing fingers, Nigeria. Anybody know where Suriname is by chance? Anybody? Suriname? Taiwan? You see any acid-fast bacilli in there? Of course you do, right? We said they would be kind of fuchsia red. Everything else is blue. It's acid-fast. But here's closer to home, okay? A place called Carville, Louisiana. A leprosarium. A self-contained compound with its own power plant, storehouses, patient treatment center, dental offices, food processing facility. These are more of a, hey, we need a place to put people. So this is the National Hansen's Disease Museum down in Carville. Patients of the U.S. Marine Hospital in Carville, Louisiana produced a set of 35 millimeter slides around 1950. So this is not that long ago, 70 years ago, from which the images were derived. In 2002, a patient's son donated the set, the only one known in existence to the museum. Father was a patient in Carville for several years, brought these slides home around 1950. The act of quarantining patients for leprosy remained law in the state of Louisiana until 1957. All right. Susceptibility testing. So what we need to do is we need to look in our book. I think our book has this outlined a little better for us than the slides. Go over to testing. Antimicrobial susceptibility testing. Okay, so this is on page 550. So susceptibility testing, because the recent emergencies, we get multi-drug resistant strains. So this is our reoccurrence of TB. Therapy has failed. Conventional diffusion techniques are not used. Drugs are incorporated in the media. Drug resistance made. Inadequate treatment. Patients non-complying, or they run away. When we started the story about running away from the hospital during treatment. Okay, so drug-resistant tuberculosis, major health threat. More than 500,000 cases of multiple drug-resistant tuberculosis occur each year. The emerging, the standard methods of susceptibility testing, including direct and indirect testing, new molecular techniques. So what is the treatment? That's what I'm going to. Anybody know what the primary drugs? This is on box 42-4. 42.4. Who wants to? We're gonna finish up with the drugs. So usually what you would get is a kind of a cocktail. 4 general methods used throughout the world to determine the susceptibility of tuberculosis. So anybody want to go through the drugs? It's on page 552 is the therapy. Am I the only one? No, there's other books here. So it depends on the susceptibility of the isolate. To prevent the selection of resistant mutants, treatment of tuberculosis requires 4 drugs. 4 drugs. So this is key because, again, I have a memory. And a memory that there is a test question talking about 4 drugs of treatment for Mycobacterium tuberculosis. What's number 1? Isoniazid, rifampin, ethambutol, and pyrazinamide. Okay, the initial therapy is all 4 drugs for 8 weeks. However, if drug susceptibility is determined for isoniazid, rifampin, and pyrazinamide, ethambutol may be discontinued. So we can start with 4. If we feel like 3 of them are doing their job, then we can drop off the 4th one. This preferred therapy, initial treatment, followed by isoniazid and rifampin for an additional 18 weeks. Okay, that's where the idea of the patient leaving before the treatment is over, or leaving care before the treatment is over. Okay, we want to make sure that that's how we end up with a possible drug-resistant strain of TB. All right, any questions? I know that was a lot on Mycobacterium. We got tuberculosis, we got avium, we got leprae in there. We've got some sputum talk in there. Good? All right. Anybody on Zoom have a question? All right, we have a day in lab where you're going to ID your organism, and then we will talk about the details of what happens after that when we get down to the lab. See you down there. Start at 12:30.